afternoon, everyone. Thank you for joining. We will begin now.
All right. Okay, good afternoon, everyone. Thank you for joining us. It's my pleasure to, introduce you, but also welcome Dr. Sara Maldonado-Martin. She is here live in person this week as part of an Erasmus Plus visit. She is coming to us from the University of the Basque Country in Spain. She's a full professor in the Department of Physical Education and Sport. She's also the current chair of her department. She's in the Faculty of Education and Sport. I will not read her entire bio. I believe it was circulated with the announcement for today's presentation. But I do want to say that Dr. Maldonado's research projects and scientific publications are mostly related to the effects and benefits of exercise training in people with various pathologies, such as obesity, hypertension, myocardial infarction, schizophrenia, bipolar disorder, and treatment-resistant depression. Today, Dr. Maldonado will present a talk which is titled, "If You Don't Step Forward, You're Always in the Same Place, Exercise as a Way of Life." So over to you, Sara. Just a house, what do you say it? Just a procedure aspect. We will keep questions until the end. And you can enter your questions in the Q&A via the Q&A button that is located at the bottom of your screen. So over to you, Sara. And I can see that there's an issue with the audio, so we'll just make sure that Sara gets some help. So Sara is at the Perform Center currently. We've had some technological challenges getting set up, so I think someone will come in and help her just make sure that the sound works. So as you know, sometimes when you change location, the security features are not the same from one university to the next. So we'll just make sure Sara gets some help. Maybe in the meantime, I can talk about you a little bit more, Sara. So Sara is visiting for the full week, and this is part of a program that is funded by the European Erasmus Plus. It's a mobility agreement. So she's been welcomed by the Concordia International office. And then she has been put in contact with researchers that do work along the lines of the work that she's been doing. So I've had the pleasure of spending a bit of time with Sara. And so we've been going around the campuses and some different research centers. So there we go. Okay, so are you all set up, Sara? Yes. Maybe unmute yourself just so we're sure we can hear you as well.
The audio is okay now?
Yes, there we go. All right, over to you.
Okay, thank you. I didn't listen to the presentation, but I guess it was perfect, Veronique. Okay, so can I start? Yes.
Yes.
Okay, thank you very much. Bonjour, I would like to speak in French, but j'aimerais pouvoir parler français, mais je n'ai pas pratiqué votre langue officielle depuis longtemps. Pour ces raisons, je devrais parler en anglais. As you can see in the slide, we have 4 different languages, and I would like to thank to Concordia University for giving me the opportunity to be here with you and to present, to share this presentation. In particular, I would like to thank to Veronique, Paulina, and Julio for the help and the time for all the preparations. We have 2 official languages, Basque, Eskerrik-asko, Spanish, muchas gracias, merci beaucoup in French, but we will speak in English. Thank you very much again for this opportunity. I am from the Basque Country, and the University of the Basque Country is located in the north of Spain, in the border near to France. And the sculptor Eduardo Chillida was asked in 1981 to make a symbol, and he did a tree and its fruit. So this is the idea. The idea is the meaning of the emblem of the University of the Basque Country is give and extend your fruit. And I will try to do it. In the Basque Country, and the University of the Basque Country is spread over the 3 Basque provinces, Araba, Vizcaya, and Gipuzkoa. And my faculty is located in the Araba campus. And the name of the faculty is Faculty of Education and Sport. And we have, and I teach in the degree in physical activity and sport sciences, located in Vitoria-Gasteiz city. As far as my curriculum, briefly, I will tell you that I have a degree in physical activity and sport sciences. And later, and you can see, because the application of the sport sciences is so rich that in my undergraduate and postgraduate training, I have been developing in different areas, such as management, performance, and finally ending up in health, the area in which I have specialized more. So after finishing my degree, I took a postgraduate in management of sports, and later master degree in high performance sports with a doctoral thesis. And in around 1997, 98, I started doing my specialization in health. So health is my primary area now, and taking into account the levels of primary and secondary prevention, and also the experience and knowledge acquired during my stays at Wake Forest University and Gloucestershire University and the posterior training courses, I asked myself it would be not possible to carry out an exercise program in people at cardiovascular risk, trying to create a multidisciplinary and interdisciplinary program. So I contact with cardiologist people, and in 2009, we started a cardiac rehabilitation program until now, trying to put the research into practice and to have the opportunity to offer different skills to undergraduate and postgraduate students. So I took my experience and my formation from Wake Forest and Gloucestershire University to bring to the Basque Country, to the University of the Basque Country, and to try to present and to research the role of exercise and healthy diet in cardiovascular disease risk. So this is the sentence that I love so much, is the unhealthy expression of genes. I mean, the inflammatory state is sensitive to physical inactivity, but can be prevented or delayed by introducing the genes in an environment of physical activity. So we are going to try to get that on people. And for that, the question is, what are we looking for? We are interested in designing an individualized training program tailored to each person, to try to shock this inflammatory state in an efficient way, I mean, fast in time. So for that, we know that at the moment, there is no pill that replicates the widespread effects of exercise on other organs. So we are going to design. I say always to my students that we don't prescribe, we design. We have in our hands the art of design exercise. For that, we have to apply the FIT PV principle. I mean, frequency, intensity, type, time, progression, and variety, taking into account the order of exercise, the kind of exercise, and the different sessions phases. So this is our art, this is our work. For that, we are very keen trying to implement interval training, because we think that less is more with interval training, but we have to be very careful how to apply a high intensity interval training or low intensity interval training, taking into account the different exercise intensities. For that, it's mandatory to do a previous and initial assessment of the person to get the different intensities and take into account the ventilatory thresholds if we have a cardiorespiratory test in our hands. If not, we have to do it with the carbonium formula, but always with objective values of heart rate. So our question was this one: in people with chronic pathologies, do we need to design a high volume of training? And in order to to test this, we program different researches. In those, the low volume HIIT or low volume LEAD was a kind of training taking into account or considering that low volume is a session where you are designing less or equal 10 minutes in high intensity or in the higher intensity. If you add all the time in these intervals in a higher intensity, there can be 10 minutes or less. So we started our primary study in cardiovascular risk in 2010 with Exerdiet HTA project on people with hypertension and overweight and obesity, and later on people with acute myocardial infarction after myocardial infarction, both of them with high intensity interval training. So we are going to try to explain our main results. This is the protocol of the first study, Exerdiet HTA, with people, as I said, with hypertension, primary hypertension and obesity. With this project, we have run 4 different theses. This is my students. And the protocol was divided in 4 different groups, all of them with hypocaloric DASH diet, but with one group attention control with only physical activity recommendations, and the other 3 groups with supervised exercise training, 2 of them with high volume, 45 minutes in total, but one of them with moderate intensity continuous training program, and the other one with high volume, high intensity interval training with more than 10 minutes in high intensity in every session. And the 4th group was supervised exercise with high intensity interval training, but low volume. I mean, less than 10 minutes of high intensity intervals in every session. So the question we try to discuss the result of this intervention to understand the potential of exercise for improving the well-being of people with primary hypertension and overweight and obesity. The preliminary results analyzing the baseline data, we try to take into advantage of the different assessments to evaluate the relationship between modified shuttle walk test with peak oxygen uptake measured in an objective way, and we created an equation to estimate the VO2 peak through the modified shuttle walk test. Although it wasn't very accurate, we can use this equation when we don't have a cardiopulmonary exercise test. And later we try to validate this equation after the program, after the exercise intervention. And the new equation has a practical application to estimate this VO2 peak above all in obese people when we don't have the cardiopulmonary exercise test. So it's a tool to use when we have not the other gold standard, that is the cardiopulmonary exercise test. Also, we characterize our sample before exercise intervention, and we realized that the average data, all of them, they presented high cardiovascular risk, taking into account the biochemical variables. So they were metabolically abnormal with abnormal obesity. The cardiorespiratory fitness that nowadays is considered a gold standard was quite low. And they present, because all of them were hypertensive with hypertension, and they had not a good adherence to healthy diet. So they presented an unhealthy diet pattern. So it's clear that it's the necessity for behavioral change in those populations. On the other hand, we assessed the cardiovascular risk with different equations, and also the vascular age, I mean, the age of the arteries that is different to the chronological age. And also we wanted to evaluate if the cardiovascular risk was associated with the level of cardiorespiratory fitness. We conclude that these equations will underestimate the risk of suffering a cardiovascular event in overweight obese women, so with hypertension compared with men, because always the risk was higher for the men, and they don't take into account the menopause state of the women, for instance. So the cardiorespiratory fitness alone, above, may not be enough to moderate the cardiovascular risk. So all of these data were at baseline. On the other hand, taking into account the cardiovascular risk of this population, we wanted to measure the association between cardiorespiratory fitness and biochemical profile. So the question was, is cardiorespiratory fitness independently associated with the biochemical profile? And we realized that a lower cardiorespiratory fitness was associated with an unhealthy biochemical profile. So it was very, very important to improve the physical activity level and cardiorespiratory fitness in this population. Again, we can say that there is a need for behavioral change in this population. Also, before the intervention, we analyzed through accelerometry with actigraph-based sleep quantity and quality in this population. So we wanted to know how was the quality of sleep in this population, and we conclude that the mean sample they showed a short and poor quality sleep. And also it was related with a higher blood pressure and abdominal obesity. So people with shorter and poorer quality of sleep, they also had or presented a higher blood pressure and abdominal obesity. So it was time to analyze what happened after 16 weeks of intervention. So after 16 weeks of intervention, we saw that very nice result. You can see here the MET values, the cardiorespiratory fitness, and you can see that the three groups within exercise intervention, supervised exercise interventions, they improve the cardiorespiratory fitness, but the HIIT groups, the high intensity HIIT groups, both high volume and low volume, they improve better or much better or significantly higher than compared with high volume and moderate intensity continuous training. And the most important thing is that there wasn't significantly differences, so there weren't significantly difference between the both HIIT groups. So the low volume HIIT was very, very time efficient to get good results. When we analyzed the values and the variables after training, we also with the sleep, we observed that the 16 week of supervised aerobic exercise program was very, very effective in increasing, firstly, self-reported physical activity. They were more active after training, reducing the sedentary behavior, and they improved sleep quality in those populations. So it was very efficient also our program after 16 weeks of supervised aerobic exercise program. But we wanted to analyze what happened when after 16 weeks, we said to people, okay, now you have to be able to do by yourself. And after 6 months of unsupervised period, we gave physical activity and diet recommendation to this population. And we assessed again with every test, every assessment again. So you can imagine what's happened when an overweight obese population with hypertension attains significant improvements in cardiometabolic health post-intervention with diet restriction. There was a significant reduction following 6 months. I mean, after intervention with exercise, supervision, and diet, everything was better. But after 6 months, body mass increased again, mean blood pressure increased again, VO2 peak or cardiorespiratory fitness was lower. So we can say that with no supervision, all of these parameters were worse. So in this paper, you can see that pre-intervention, our population presented values of obesity. LDL was higher than normal values, as total cholesterol, at liver enzymes, glucose, protein C-reactive, systolic blood pressure, and cardiorespiratory fitness was low. So population was characterized as metabolically unhealthy obese. After 16 weeks with aerobic exercise and diet intervention, we got that this population will be metabolically healthy overweight. You can see here the values. They progress from obesity to overweight, and the only biochemical parameters with no normal values was the LDL. But after 6 months, you can see that many of the parameters were again not healthy. So we should get that this population will be fitter, and with intervention, with exercise intervention, although they are overweight, this is not the main value. The more important thing is to be fit, but with no supervision, the sample progress or digress from metabolically unhealthy obese to metabolically healthy obesity after 16 weeks of training. But again, after 6 months of no supervision, the sample is presented as the beginning with metabolically unhealthy obese. This is our intervention with hypertension and obesity people, but we wanted to go further and try, after the results, what's happened with a person or with people after myocardial infarction. I mean, secondary prevention. We have another successes with this project, and this project we took away the moderate intensity continuous training, and we did it with 3 groups: attention control, and 2 groups with interval training, high volume, low volume. And in this case, we had Mediterranean diet because they were cardiovascular patients. So the discussion of the protocol was to compare the effects of 2 different volumes of HIIT programs with Mediterranean diet recommendation on people after myocardial infarction. In a primary paper, in the first paper, we confirm that the low volume high intensity interval training was very efficient, because both groups, by high volume and low volume, they improved the cardiorespiratory fitness with significant differences between control, attention control, and HIIT groups, but not between HIIT groups themselves. So this is the main conclusion, that low volume HIIT, less than 10 minutes in high intensity in one session, may be a potent and time-efficient exercise training strategy to induce cardiorespiratory fitness in this population. Take into account that if we do a design with this low volume HIIT, you have time in the same session to include also resistance training, that this is the goal. And you can see here in the video how do they work. Our second study, we wanted to compare the effects of these different protocols, HIIT protocols, on chronotropic responses. You have to be aware that this population, normally they have beta blocker treatment. So on beta blocker treatment, beta blockers affect to the heart rate, and sometimes they have chronotropic incompetence. I mean, they have difficulty to get a higher heart rate. So after 16 weeks of training with these protocols of HIIT, the low volume was again very, very efficient, because both groups at high intensity interval training, they improved heart rate peak, what is very, very important to get a better response of heart rate. They improve the recovery heart rate. So at the end, we can say that they have improved the autonomic nervous system. I mean, the capacity to stimulate the nervous system sympathetic and also the parasympathetic. In the third study, in the third paper for this study with myocardial infarction people, we analyzed different questionnaires. We wanted to know the impact of this kind of training in quality of life, mental health, also Mediterranean diet adherence, and the physical activity habits, with different, as I said, with different questionnaires. And we can conclude that thanks to this kind of training, and also if we associate the emotional health with the questionnaire to the other questionnaires, we conclude that there was a better emotional health related to a lower sedentary behavior and higher values of heart rate, of quality of life, and how much metabolic expenditure they have, and also with vigorous physical activity and med diet. I mean, the better emotional health when people move more, have a higher energy cost, they do more vigorous physical activity, and they eat better. So there is a connection between the emotional health and the lifestyle at the end. We wanted to go further, and in this kind of people, myocardial infarction people, we wanted to analyze if the low volume HIIT was able to attenuate the dysfunctional ventricular remodeling after acute myocardial infarction. So we have very recently published this paper, and in this paper we have analyzed with echocardiogram and different biochemical indicators of left ventricular remodeling. I mean, the proBNP, the ST2, and the creatine kinase, that in higher values they are not very healthy. What was the result of the responses after interval training? So the conclusion, I thought this infography is realistic to be the results, to see the results. You can see here, this is at the beginning. So when we apply the aerobic high intensity interval training after 16 weeks, and the control group. The control group only training recommendations, the wall signing increased diameter and diastolic volume. So at the end, there was no improvement in systolic function with a deleterious ventricular remodeling, with a big dilation, excuse me. But after training, it was fantastic with echocardiography that we have seen a prevention of wall thinning. There was an increase in ventricular mass, diastolic diameter, diastolic volume, and also a reduction, excuse me, of pro-BNP and STG in this population. The only thing that there was a risk of CPK elevation in the high volume interval training. But at the end, there was a favorable remodeling attenuation. So the conclusion in this paper was that the low volume is a fantastic, great proposed as a clinically time efficient, a safer strategy to attenuate this dysfunctional remodeling and preventing wall thinning and improve left ventricular function, better than high volume HIIT, because with the high volume HIIT, we have seen higher values of creatine kinase. So the question is, how gives more? We think that this is fantastic. This is very applicable. So we were further, we wanted to see if we were able to improve the mental activity health through high intensity interval training. Can we work with this kind of training in other populations? And from the last GGR, we can you are going to see that we have seen in other populations, but because we wanted to see if there was an effect in this crosstalk between skeletal muscle and the brain, because we know that there are studies presenting the neuroplasticity of the brain, I mean the ability to change and adapt due to the experience and also to exercise. So we are going to implement in the following studies the low volume HIIT plus resistance training. I mean the application of concurrent exercise training. Knowing that low volume HIIT is a very, very efficient method, we are going to add the resistance training, taking into advance the general recommendations. So now we are working in 3 different populations: people with schizophrenia, people with bipolar disorder, and people with treatment-resistant depression. And in the 3 different groups, we are applying the concurrent training. I mean, low volume HIIT and resistance training in the same session. We have an agreement, a great agreement with the mental hospital, psychiatric hospital in our city. We have worked during the last year with this study, Cortes-SP study, in a schizophrenia population, with a very, very good agreement and hard work with psychiatrists and also with our students in exercise sciences. So we have some publications already, some of the papers. We have also a T-shirt with this study, the Cortes study. We also characterized the population, the schizophrenia population before the exercise training. We have seen that they present a metabolically unhealthy overweight, because this population, as you will know, they have with a lot of medication, and sometimes the secondary effects of the medication has effects in metabolism, and if they are not a fit population, they are not very, very active. So they present a profile with a metabolically unhealthy overweight, with a low cardiorespiratory fitness, a very low ventilatory efficiency. So the change for the change of the lifestyle is also recommended. We also take into account the previous study. We have created an equation to estimate the VO2 peak, the cardiorespiratory fitness, through the modified Satte-Walk test, the field test. So you can use also this equation to estimate the VO2 peak, just in case you don't have the cardiopulmonary exercise test. The protocol of the exercise project, as I said, was low volume HIIT, less than 10 minutes in high intensity in the same session, with a total volume of 20 minutes, and resistance training over 20 minutes. And here you can see unpublished data. They are under review. After 5 months of 3 days a week with exercise training, the sample is very big, 112 people with schizophrenia. I don't think there is in the world another sample with this mental disorder, with 53 people in the control group and 59 in the exercise group. And you can guess what happened with this population after training. We have said which is the baseline characterization or profile, with body mass index in overweight, low cardiorespiratory fitness, and biochemical state was not very bad. But after 20 weeks with 3 days a week training, concurrent training, the body mass index was a little bit lower, not significantly, but it's important not to have more weight and to have a little bit less weight, because it's very difficult since the medication has a great effect in metabolism. But we have get a higher cardiorespiratory fitness significantly, and biochemical profile was the same. So we have got, after 20 weeks of training, that this population will be metabolically healthy overweight, and the control group maintain or keeps as metabolically unhealthy overweight. And this is an important result, because we wanted to go further and not only to analyze quantitative data, but also qualitative data. And we are very proud of this paper. It has been recently accepted. And the question was that we wanted to know the subjective experiences of the participants. So the title, you can see, it helped me to disconnect my mind from the problems. So this is an important paper analyzing the subjective experiences of this population, because sometimes the quantitative data, they don't say everything. So the findings highlight the participants' perspective in supporting an out-of-hospital exercise program as an acceptable and beneficial adjunct to usual treatment in this population. So we are very, very proud of these results. I put in Twitter this comment, because I think it's very important to continuing to enjoy and get excited every time. For me, I see how through exercise, movement, and music, we manage to get different people with different pathologies to keep smiling and strive every day to be there. For us, exercise is health, joy, and life. And anyone who still doesn't understand it or doesn't want to understand is due to lack of information or our ignorance. So for me, it's very, very important to see how they enjoy with exercise sessions. Going and finishing in 10 minutes, we wanted to apply our research in primary and secondary prevention through exercise, because we think that is our mission also, to promote this excellence. So knowing that the worst leading causes of death, even the COVID is there, but we continue to be many people is the mortalities with cardiovascular diseases is the main no communicable disease. So the cardiovascular disease, along with diabetes mellitus and chronic obstructive pulmonary disease and cancer, they are the main leading cause of death. So the prevention is very, very important. So we need primary and secondary prevention programs, including exercise in all of them. And also because the last guidelines on cardiology, they present the exercise as the main goal to prevent another pathology. So it's very important for us that the clinics, they do the diagnostic, they do the risk stratification, but they have to share decisions with the patients, because the person has to take control of his or her disease and not to expect that medication will do all the work. And exercise prescription and design has to be more rigorous after the previous or the baseline assessment. So this is our primary and secondary program in our city in Vitoria in the Basque Country. So we have the cardiologists who derive and they do all the baseline assessment with the drug optimization, and they decide to start the exercise or not. And when they approve for the program to start, they apply the exercise test, and the patient will be in our hands for the exercise program and under the nutritionist and psychologist for the other treatments. And exercise as an adjuvant program is very individualized, and we design the aerobic, the resistance, and the respiratory training with the goal to improve the functional capacity. So the 3 Ps are very important: prioritize, personalize, and prescribe or design, as this paper that I like very much present. And after that, is very, very important. Again, I have to highlight that the intensity, the exercise intensity ranges is very important to individualize, because when we have the different ranges for every person, low, moderate, high, and very high, we are able to design the interval training that we know from the research that we are going to get very, very good results. So I expect that you are seeing the video. In the exercise program, in the initial assessment, after the patient has signed the informed consent, we explain the program. We do the initial questionnaires. We design the different intensity ranges. And we apply the intervention with always with concurrent exercise, resistance, and aerobic training, and also multi-component training with equilibrium, trying to work the equilibrium, and a final assessment after 36 sessions with a final report and also recommendations. So to finishing, I would like to remember you in our program based on the research. Our program will be a frequency of 2 or 3 days a week. We implement always interval training, at least 2 days a week, progressing from low intensity interval training to high intensity interval training, always in every session with concurrent training and multi-component. The volume always is low, and always we apply a progression and a variety. And to finish, I hope I give you a nice spread our fruit through the world, in this case to Concordia University. And thank you very much for all of you. Merci beaucoup, the phone de care. And now I am open for every question that you want. Thank you very much. Merci beaucoup.
Wow, thank you, Sara. Thank you so much. Great presentation. You've certainly covered a lot of the studies you've been doing at back at your hometown. I don't see any questions right now in the Q&A. So again, anyone who wants to ask a question, please feel free to use the Q&A, and I will be able to read the questions to Sara. Maybe I I saw your other presentation yesterday, and we got to discuss a lot of these things. I was curious, in your earlier findings, the shuttle walk test. I've done a bit of work on this myself. I was just wondering, what do you think in your first study where you looked at it, you validated it against a directly measured VO2 peak, and you said it didn't do a great job in that population. What do you think was the issue there? Do you think there was a ceiling effect because it's got to be a walking test?
It's a walking test, but the modified Sate walk test is a peak test. It's not
I know them well. But usually those tests do a really good job at shuttle tests do a good job at predicting VO2. So I'm wondering if your population, because there's shuttle runs as well that exist, right? There's shuttle walks, but shuttle runs. And if you do a shuttle walk, you're not supposed to let your participant run. And then sometimes they become biomechanically limited because they can't walk faster, but maybe they could jog a little. So I was just wondering where you thought the problem occurred with these. It was in your overweight and obese hypertensive participants, correct?
Yes. So it's clear that when they started to run a little bit, they stopped very early.
Okay.
So as soon as they start running, maybe it's just two runs, no more.
Okay.
The thing, other limitation in our study is that we did the cardiopulmonary exercise test on bike, and modified Sate walk test was walking. So this is one of the limitation, but I think we use quite often this equation when we don't have a cardiopulmonary exercise test. So it's because there is no. There are other equations, but maybe these equations are fixed in this specific population, and also with the population with mental health, there are no equations in this population. So it's true that with hypertension people, this is the reason I think, because the equation is more the estimation is better when the people is more obese, because as soon as they start running, they cannot run, so they stop. So the estimation was better. I don't know if I answered you.
Yeah, no. I just wondered because the test was developed by you used the one from Sally Singh, correct? Singh?
Yeah.
Yes, so she works mostly in chronic respiratory disease. That's why I know the test quite well. So that's why I agree with you that we have to validate those protocols in different populations, because you can't use necessarily the same test or certainly not the same equation. Yes. So I just wondered. Seeing that there's no new questions, I'm gonna come with another one. I see you've got like experience with such a variety of populations. Usually recruitment of participants, especially like people with clinical or chronic conditions, can be very, very challenging. I know that with certain populations, you have to approach 6 to 10 people to get one participant. So I was wondering, now that you've got such like a vast experience, did you see differences across populations for the challenge of recruitment?
Okay, as you have said, the recruitment is very, very, very difficult. So the thing is that with the schizophrenia people, we have had a great group of psychiatrists. How do you say? Psychiatrists. They were very, very involved. And in fact, the pandemic was in the middle. We had 1 year and a half for stop it. But we have got, because they were very, very involved. Maybe we say that maybe there is not more people with schizophrenia in all the area, because we have recruited all of them. So it's really difficult for that. It's because they came to us.
No way.
We didn't go to them for the study. So they came to us for the exercise application. So they were very, very interested in this study to apply exercise.
So we're back to the conversation we had yesterday about the importance of physicians buy-in the projects, because otherwise you're really struggling. Yeah.
Yes.
Okay, I see I have a colleague of mine, Dr. Richard Courtemanche, has a question, so I'm going to read it off. So he says, in looking at the effects of exercise prescription on brain health, what are some of the markers you find would make the bridge between exercise and the brain? So what are some of the mechanisms? So I did see you wrote lactate or BDNF, etc.
Okay, at the moment we have analyzed only the cardiorespiratory fitness related variables. There are other two theses with the psychiatrist. They are going to analyze the BDNF, and also there has been other theses with the psychologists that they have analyzed the how do you say the image with the brain, the MEA, the
EMG.
The
images, EEG.
The images in the brain. They were
Oh,
in the scan.
Oh, the scan. Okay. Sorry about that.
So they wanted to analyze if the images in the brain, they change after the intervention, and also if there was a change in the hippocampus. So I cannot say now the results because they are analyzing now. So the BDNF will be analyzed for following year, I think. So there are differences in because this is the main outcome for the psychiatrist, the BDNF. So they wanted to analyze if there were changes after exercise training in this variable because it's very important. So biochemical variables related to the brain and also the images are analyzing at this moment.
Okay. Are they MRIs?
Yeah.
Okay, there we go. Thank you, Richard. Richard wrote that in the chat. Okay. I mean, I don't. I had a chance to ask quite a few questions. I guess maybe we can talk about your. We've got a few minutes left. We can talk about your exercise protocols. You're big on interval training as we saw, and you tried, and I agree that the high volume HIIT can be quite a lot to take on for clinical populations. So I find it very interesting, the option of a low volume HIIT. Have you administered it in a group setting? You did, right? Because we were seeing the participants pedaling when. Okay, so how do you handle like the management? Because I mean, from a kinesiologist or exercise physiologist point of view, someone who's on the floor, you're managing a group. It's much easier if they're all doing continuous training, because then you get them started and you can take some measurements and things like these. So how do you handle like several participants at different places in their interval training?
So we have done with the schizophrenia people. We have done also with 8 people at the same time. So they start at the same time. So we have different papers, and each paper with each person. So we can they start at the same time. We are with music, so they do at the same time. So maybe are 3 minutes warming up, and after in the second minute, when 10 seconds are left, say, come on, in 10 seconds we're going to start, and you are going to work harder. And 30 seconds very strong, and later 1 minute for relaxing or with a lower intensity. So it's because they start at the same time, because the protocol is the same for all of them. This is when we do the research. And when we are in the clinic, maybe some are in the treadmill and others are on the bike. So we have different where maybe we are with two trainers in each session. So we share the work, but it's not difficult. It's not difficult.
I asked because we did the same thing. We did a trial, and so for the interval training, it was 8 participants at the time. So we had actually a little buzzer as well, even a sound, because we were afraid of being distracted. But I find that in a regular clinic or even because I'm assuming we might have some kinesiologists on the talk or listening, and when you have to apply this, and you don't have necessarily the benefit of like this one group coming in at the same time, but people come in and out and all that. And
yes,
I do think it's something to think about. That the challenge of administering HIIT is certainly greater than continuous training. So I think for trainers it's more uncomfortable. So I think that's why some people resist.
Much more. Yes, you have to be on.
Yeah, absolutely.
Yeah.
Okay. Well, I'm not seeing any other questions, so I'm going to thank you so much, Sara. It's been really great to hear you talk, and I'm glad because today you were able to go cover your second part of your data. So this format suited your talk well, I thought. So thank you, and I'll see you in a few minutes. I'll come across to perform and meet you. So hope you have a good rest of your stay in Montreal.
Thank you, all of them. Thank you very much.
Bye-bye.
Bye.